Increased inflammation. Inflammation is measured by elevated levels of C-reactive protein CRP, and high sensitivity C-reactive protein is an established risk factor for systemic cardiovascular disease, including PAD. And diabetes mellitus is a hyperinflammatory state with elevated levels of C-reactive protein and other markers of systemic inflammation. And some of these inflammatory markers may also be important in PAD pathogenesis. As an example, C-reactive protein has procoagulant effect related to its enhancement of tissue factor expression. Hyperglycemia from diabetes also leads to overproduction of mitochondrial reactive oxygen species ROS via the protein kinase pathway. Once activated, PKC leads to a structural and functional changes in the vasculature, including changes in cellular permeability, inflammation, and formation of new blood vessels, angiogenesis, and cell growth, and extracellular matrix expansion, and apoptosis, the programmed cell death. Endothelial dysfunction, which is a dysfunction of inner lining of blood vessels, is extremely common among patients with comorbid diabetes and peripheral artery disease (PAD). In healthy blood vessels, endothelial cells synthesize nitric oxide, which is a potent vasodilator. It makes the blood vessels larger, that inhibits platelet activation and vascular smooth muscle migration. Diabetic hyperglycemia means when the blood sugar is running high for a long time, induces an imbalance between nitric oxide bioavailability and accumulation of ROS, leading to impaired vascular health. And endothelial dysfunction of inner lining cells in the blood vessel in diabetics are a result of increased synthesis of vasoconstrictors and prostanoids. Mitochondrial ROS production also enhances advanced glycation end products and receptor signaling, which in turn activates ROS sensitive biochemical pathways, which causes more endothelial dysfunction and vascular homeostasis. There is an element of enhanced vasoconstriction. The blood vessels get constricted because of all these changes and release of chemicals. And the PKC activity leads to increased production of endothelin 1, ET1, and that leads to enhanced vasoconstriction and platelet aggregation. Platelets start clumping together. Notably, endogenous ET1 has enhanced vascular activity among patients with type 2 diabetes. And in the setting of diabetic hyperglycemia, increased PSE activity changes the nitric oxide signaling and enhances vasoconstriction. And these two processes are important in the pathogenesis of PAD. So, at one end, there is a heightened activity of PKC and there's changes in nitric oxide signaling, and both leads to vasoconstriction, the constriction of the blood vessels, leading to the pathogenesis of peripheral artery disease. Enhanced thrombosis. Among patients with diabetes, insulin resistance and hyperglycemia contribute to a prothrombotic state characterized by increased platelet activation. Platelets are more likely to clump together, and coagulation. They start forming tiny clots. Insulin resistance increases level of plasminogen activator inhibitor 1, PAI1, and fibrinogen. And patients with diabetes mellitus and poor glycemic control have high levels of PAI1. And some studies suggest that treatment with glucose lowering agents like glipizide and metformin decrease levels of PAI1. In addition, hyperinsulinemia and hyperglycemia can act synergistically to increase monocyte expression of tissue factor that further increases procoagulant activity and thrombin generation. Microparticles, which are vesicles released in the circulation from various cell types in response to apoptosis or activation, and they are increased in amount in patients with diabetes mellitus and independently predict cardiovascular events in patients with a stable coronary heart disease. Microparticles are also increase coagulant activity in the endothelial cells of patients with diabetes and promote thrombus formation at sites of injury. So, increased platelet derived microparticles are also associated with PAD and may represent a pathway of shared pathogenesis for PAD risk among patients with diabetes.